Good morning, everyone, and thanks for joining us for our presentation today, Atrial Fibrillation. You make my heart skip a beat. Before we get started, I just want to mention a couple little housekeeping type things. We are going to keep all of the attendees on mute during the presentation, just to kind of cut down on any background noise that might be happening wherever you are at. If you do have any questions, you can feel free to either type those into the chat, or we will open it up for questions, and then you can feel free to unmute and ask your question at that point. I will be sending a follow-up email later today with a link to the recording, so if you miss anything or want to re-watch it at any point, you definitely can. And I'll also include a link to an evaluation. So if you could complete that, we really appreciate your feedback on the program. So now I'd like to turn it over to Derek Stebbins to start things off.
Thank you, Laura. Good morning, everyone, and thank you for joining us today. My name is Derek Stebbins. I am the Operations Manager here at Heart and Vascular in Pro Healthcare. We're so pleased that you could join us today for our education session, You Make My Heart Skip a Beat, pertaining to atrial fibrillation. I'm very excited to introduce you to our physician expert and speaker in just a moment. First, we wanted to highlight and reiterate for many of you who may know through other promotional materials, this is a very exciting time of year for us in heart care, as the American Heart Association recently celebrated its 100th anniversary. And I think we would all agree that we can take pride and assurance in knowing that our approach to cardiovascular disease prevention, diagnosis, and treatment has taken monumental leaps forward since 1924. Pro Healthcare is pleased to be a longtime partner of the American Heart Association and strong supporter of program initiatives that strive to provide the highest quality care for our community in the Milwaukee area and throughout Southeast Wisconsin. Your speaker today is Dr. Sam Asneroff, electrophysiologist. Dr. Asneroff began his work with us at Pro Health back in March of 2022 and joined our team full-time in July of 2023. He's a graduate of the University of Kansas in Lawrence, Kansas, as well as the University of Kansas School of Medicine. He has also completed fellowship training in general cardiology at the University of Kentucky in Lexington, and also a fellowship in clinical cardiac electrophysiology at Vanderbilt University in Nashville, Tennessee. Dr. Asneroff joins us at Pro Health after previous staff coverage at Boulder Heart in Boulder, Colorado. I am pleased to introduce someone who has been an outstanding addition to our heart and vascular team. He is a true asset to our electrophysiology patients, and what I think you'll take note of this morning is he's just a great teacher. So without further ado, Dr. Sam Asneroff.
All right, thank you so much for that introduction, Derek. And thanks everybody for joining. And for those of you that might be watching offline after the fact, I'm really glad that we're making this available as a recorded session. So I am the medical director of the cardiac electrophysiology program here at Pro Health. We have a lot of ground to cover, so let's just get right into it. So let's talk about atrial fibrillation. All right, so what is atrial fibrillation? We're going to start with that, just kind of what is the core concept here. The first thing I want to say before we get into anything else is that atrial fibrillation, a lot of people think of as a disease, and if any of you have come to me as a patient, you might have heard me refer to it as a syndrome. That's kind of one of my key phrases that I like to use. What do I mean by that? Calling AFib a syndrome reflects the idea that AFib is not a single disease. It is a collection of conditions that may all lead to the same net effect, which is atrial fibrillation. And then from there, the AFib itself may lead to then a variety of outcomes kind of downstream from it. So basically, you know, there's a bit of a funnel effect into the diagnosis of effect, and then there's a bit of a kind of reverse funnel effect in terms of potential clinical outcomes. And so we have to consider a lot of different factors when it comes to atrial fibrillation in terms of what possible causes might be contributing to an individual patient's condition and what possible outcomes might be need to be thinking about. And not all causes and not all outcomes are necessarily universal. All right, so we're going to take a look at heart activation. Sorry, there we go. All right, we're going to take a look at the heart activation in normal rhythm, in what we call sinus rhythm. And what we see here, we're going to start in the atria, the upper chambers of the heart. That's what provides things like coordinating to the timing of the heart's chambers, regulating filling pressures and blood volume. Atria actually have, believe it or not, a hormonal function where when blood volumes get too expanded, they actually can secrete a hormone that tells the kidneys, hey, time to get rid of some fluid. Whereas when we're kind of relatively dehydrated, they pull back on that hormone. So they're really more support chambers as opposed to the true pumping chambers of the heart. Whereas the ventricles, the lower chambers of the heart, that's where we see the pump function. That's where when we think of our heartbeat, it comes from the ventricles, the right ventricle and the left ventricle. When we talk about pulse, when we talk about blood pressure, those are the things that actually come from the ventricles. These are critical to the heart's function. So, all right, so ventricular fibrillation is an immediate life-threatening emergency, whereas something like atrial fibrillation, as we'll see, can affect heart function, but doesn't necessarily translate to an immediate medical emergency. All right, so during AFib, we're going to now zoom in on a tissue level. And what we're seeing here is an activation model of heart tissue during atrial fibrillation. What we see here is, as opposed to this nice organized wavefront of electrical activation through the tissue, what we see here is kind of chaotic, meandering wavefronts. There's multiple wavefronts that you can see kind of running into each other, breaking. They're kind of going everywhere that there's available tissue for electrical activation. So it's disorganized. That's the main thing to take away from this, that unlike just about every other arrhythmia we talk about that is coming from a specific place in the heart or that may follow a specific circuit inside the heart, with AFib, there is no organization. It's this kind of, electrical riot, if you will, in the upper half of the heart. So what does that lead to? Well, we lose that optimization function that the atria have. We lose the timing regulation. We lose the reservoir function of the atria. We lose the pressure optimization. And what that leads to is a potential loss of heart efficiency. And again, as I've mentioned with the last slide, this is not immediately life-threatening in the vast majority of conditions. Of course, in medicine, there's variables upon variables. And yeah, in some cases, AFib could actually compound an already difficult situation. But generally, we don't think of this as a true medical emergency. So the consequences of atrial fibrillation. So at the top left here, we could see what we would call normal sinus rhythm, whereas at the top right, this is an EKG demonstrating atrial fibrillation. And I understand, not everybody here is an EKG expert, but what we're looking at here is a kind of a timeline representation of heartbeats. And, you can kind of tell at a glance that there's a lot more heartbeats in essentially the same time frame, and they're a lot more irregular. And that's kind of one of the most immediate consequences, one of the most immediate consequences of atrial fibrillation is if folks are aware of AFib as it's happening, what they'll primarily report as their very first symptom is palpitations, the sense of rapid and irregular heartbeat. With that, then you can have loss of heart efficiency, where we're talking about shortness of breath, fatigue, chest discomfort, some lightheadedness, things like that. Basically, the heart is not pumping as efficiently as it should or could be. And then over the long term, this actually could lead to a risk of heart failure. And then there's a risk of stroke. That is kind of the most significant, the most consequential potential outcome of atrial fibrillation. So what I'd like to show you all here is a video. This is an open heart surgery. This is a heart that there's two things to note here. So you could see the atrium fibrillating here, quaking really, really, really quickly, but then the heart as a whole, you could see the whole mass is actually moving a whole lot slower, but still irregular and still faster than it would be. So what you're seeing there is the activation of the atrium as opposed to the activation of the ventricle in this heart that's in AFib. All right, so to shift gears a little bit, we're going to talk about the AFib timeline. So this is one of the core concepts that we talk about with patients. So AFib is a progressive disease. I like to refer to it as a wear and tear kind of phenomenon in the heart. And with just about any progressive wear and tear kind of disease, there's going to be some degree of aging related factors. Some of that is going to be normal. Some of that is going to be abnormal, and that's not necessarily a black and white thing. There's definitely, some shades of gray. Is just with everything else. If you think of things like knees and backs and things like that, they all tend to wear out over time. But in some folks, that wear is kind of, just leads to a little bit of a creak, and some folks that wear might lead to the need for like a knee replacement surgery. So there's definitely a spectrum of progression there. In addition to just normal aging, there's additional wear and tear as we talk about cardiovascular disease induced remodeling in the heart. So what does that refer to? Well, that refers to things like hypertension causing more strain on the heart muscle over time. That refers to things like valvular heart disease, or if somebody's had a heart attack and their heart pump function is now not as, like the physical pump function in the ventricles is not as efficient as it could be, that then leads to more wear and tear on the system as a whole. And then on top of that, there's this concept that AFib begets AFib, that the time we spend in AFib in itself then leads to further remodeling that makes AFib more likely. And so this is kind of the key concept in all of this, that yes, there's normal aging related progression, there's cardiovascular disease related progression, but then the time spent in AFib then determines that person's likelihood of coming out of AFib either spontaneously or with the interventions that we take. And that makes a difference in terms of the likelihood of success that we can expect with the interventions that we offer. So when I meet somebody in clinic, I don't get to see this like nice graph at the bottom of how their AFib, of what factors contribute to what. All I really have to go off of is their AFib history. And so the behavior of atrial fibrillation over time is our biggest clue to disease stage. So what you're seeing here with this timeline at the top is AFib events. And you can see that for the first few years in this hypothetical patient's life, they had episodes of AFib where AFib would start and stop and start and stop. And you can see that there's a little bit of an acceleration there over time until their first. I'm sorry, folks. It appears that Susan might need to mute herself. So what you can see is that this patient might have their first prolonged episode of atrial fibrillation here at about age, we'll call that 45 or so, where it's no longer just a line. It's kind of a progressive event of AFib. And you see that right above that, there's that marker of CV. That's a cardioversion. That's that person's cardiologist then shocking their heart back into a normal rhythm. And then they do fine for a while. And then they might have another blip of an episode that terminates on its own, and then they might need another cardioversion, and another, and another. And over time, this is the natural history of atrial fibrillation, where it becomes more and more difficult to control, and it's our job to step in with interventions, ideally in the earliest possible stage, but that the timing of those interventions is really key. And what's available to a patient in terms of AFib control is really going to depend on where they are in that timeline. And at some point, we may actually need to concede that, gosh, this particular patient's AFib is now past the point of what we would call rhythm control that we'll talk about a little bit later. We have to accept the fact that their AFib is so entrenched that we're not going to be able to get them very far by trying to control the AFib itself. And that's exactly what that point makes right there. So, consequences of atrial fibrillation. Let's shift a little bit. So I mentioned that stroke is the biggest, the potentially most devastating consequence of atrial fibrillation. So what happens in AFib that actually predisposes folks to stroke? So there's a pocket of the heart called the left atrial appendage, which tends to form these blood tends to pool in that structure and form a blood clot that could then travel out of the heart and travel to the brain, causing a stroke. It doesn't necessarily have to travel to the brain. We've seen blood clots land in other places in the systemic circulation, but because the brain is such a powerhouse of an organ, it kind of gets first dibs at blood flow, which is a good thing that we get a lot of blood flow, and the most direct shot from the heart just goes straight up the carotid arteries to the brain. But unfortunately, that also gives a blood clot potentially the most direct path out of the heart to the brain. So how do we determine stroke risk? Well, not everybody's stroke risk is the same. And that's key to kind of how we determine what therapies we need to offer as well. Is patient A versus patient B, do we need to offer them the same therapies? Do we need to offer one more aggressive therapies than the next? Well, what we do is we look at certain risk factors that statistically predict people's stroke risk. And you can see here this CHADS 2 VASC scale. It's a 9-point scale, and there's certain factors that we plug into it. And then that translates to a per year risk of stroke. And what's important to understand there is that by far the most common conversation we have is with folks in the 1 to 3 range. And if I'm talking to somebody who has a CHADS VASC score of 3 and they say, well, gosh, 3% risk of stroke, that actually doesn't sound so bad. And I say, well, yeah, that's true. It doesn't. But over the next 10 years, that adds up to a 32% risk of stroke. And all of a sudden, that sounds a whole lot worse. And so it's really important to understand that when I'm talking to somebody in the clinic about their risk of stroke, I'm not just talking to you about how you're looking today or tomorrow. What I'd like to ensure is that in a decade or in 2 decades or whatever the relevant time frame is for where one might be in their life, that we maintain their quality and quantity of life, that in 10 years they don't have a devastating clinical event because we didn't take the time to prevent that up front. So stroke prevention, and this is a picture of this left atrial appendage. You could see that kind of ruffled structure to the left of the image there. So medications are usually where we start with stroke prevention. Coumadin or warfarin is the traditional option. It's been around for, greater than half a century at this point. It requires monitoring of the blood thinning index that tells us how active that medication is in that patient's body. And it really takes a lot of steering over time. There is no such thing as here's your dose, have fun with it. We have to make dose adjustments incrementally, repeatedly, for the duration that a given patient is on this medication. And of course, that means a lot of interactions with the healthcare system, a lot of time to travel to those appointments, a lot of dose changes, and it really takes an effort on the part of the patient. Whereas the newer generation of blood thinners, what we call direct oral anticoagulants, that's Eliquis, Xarelto, Pradaxa, they are much easier to take. You take the pill, you're protected from stroke. You, in theory, should not have an elevated risk of bleeding. We'll talk about that here in just a bit. They are more expensive. They're getting better. But the difference there is that you're relieving the cost in terms of lifestyle and effort and things like that. They are cleared by the kidneys. So patients who have abnormal kidney function, we may have to do a dose adjustment to a lower dose, or potentially have to say, gosh, you're not a candidate for this medication because the kidney function just prevents us from being able to use it. And then there is well, there's a couple of varieties of procedures, but ultimately they come down to an anatomic disruption of that kind of ruffled space, the left atrial appendage. So let's talk about the risk of associated bleeding with blood thinners first, and we'll talk about the procedural things. So it's really important to understand that blood thinners or anticoagulants do not cause bleeding. Now, people can have bleeding when they're on anticoagulants, and that bleeding will be worse. That bleeding will be more extensive than it otherwise would have been. And it's important to understand that, once in a while, I'll get a phone call from somebody who just recently started a blood thinner, and they say, oh gosh, all of a sudden there's blood in my stool, or all of a sudden there's blood in my urine. And generally the response is, it's not all of a sudden. It was there all along, but it was what we would call microscopic or subclinical. It was not enough to be noticeable. But now it's a larger volume of blood that now is presenting itself as a bleed. It's important to acknowledge that it's got to be coming from somewhere. Normal tissue that does not have a bleeding source is not going to bleed just because we put somebody on an anticoagulant. So if somebody's got blood in their stool, we need to look for a stomach ulcer. We need to look for a tumor in their colon that might be bleeding. We need to look for what we call an AV malformation, bleeding in the urine. There may be kidney stones. There may be, again, a tumor or some kind of erosion in the bladder that we may need to look at. So we may need to work that up, address the bleeding source if it's something that we could address, and then we resume the blood thinner, assuming that we were able to address the source of that bleeding. It's important to understand that there's kind of categories of bleeding. So things that we would consider minor bleeding are basically listed here: stool, urine, nosebleeds. Occasionally some people might be in a profession that kind of leads to repeated cuts and such. And yeah, it's obviously not pleasant. It's obviously something that we're going to want to help you deal with, but it's not life-threatening. Whereas major bleeding, these are events where, hey, if it happens once, we may actually need to be talking about, okay, we might need to rethink this whole thing. So any bleeding into the brain, no matter how small, no matter how scant, that gets our attention very quickly. Bleeding which was voluminous enough to require treatment with a blood transfusion. Bleeding which needed surgery because of the treatment refractory nature of the bleed, or the volume of the bleed, where we needed to actually go in and physically address it. Now, we're not talking about like a colonoscopy to find what's going on, but like emergency surgery. Those are potentially life-threatening major bleeds. Those are ones where, hey, if this happened once, we're going to be having a conversation about, hey, this isn't going to work, as opposed to minor bleeding is something where we'd be willing to, let it happen a couple times before we start saying, okay, it's time to really rethink this. So what about patients that are truly unable to take blood thinners? They either had a single major bleed or multiple episodes of minor bleeding, where we are looking at this and saying, okay, the pros and cons are really not aligning here. Well, this is the procedure that I had alluded to. So this is what we're talking about when we talk about an anatomic solution. So this is a closure of the left atrial appendage. In this case, what I'm showing is a plug that's actually being placed into that anatomic structure. This prevents blood from getting into the left atrial appendage, which therefore prevents that blood from clotting and those blood clots from then getting out. The long-term stroke risk reduction is roughly equivalent to blood thinners. It does require temporary blood thinner therapy, though. I think that's a kind of a counterintuitive point that is really important to understand going into something like this. This is a foreign body that we're placing into the heart. The body will recognize this as a foreign body and want to actually form a blood clot on top of it. So if all we did is this and nothing else, we're actually potentially increasing stroke risk. That's why it's vitally important to understand that there's a commitment to blood thinner therapy temporarily until this device has overgrown with the body's own tissue. So the body actually forms some scar tissue on top of it that then now looks to the body as just its own tissue, and then it does not recognize it as a foreign body anymore. So that's an option that thankfully is available. It's in the last 10 to 15 years, this is something that's been developed, because in the past, if somebody had recurrent bleeding or major single bleeding on blood thinner therapy, unfortunately, at that point, we're kind of talking about what's the lesser of two evils, being exposed to the risk of stroke or being exposed to the risk of bleeding, but you really couldn't, have your cake and eat it too. In this case, this takes a very difficult situation and gives people a path forward that's still, a way to keep them safe. So let's shift focus a little bit now to, well, how do we, when we talk about controlling AFib, what is rate control? What is rhythm control? What do all these words mean? How do we utilize these strategies? So rate control is addressing the rapid heart rates associated with atrial fibrillation, like we talked about kind of basically at the top of this talk. The fast heartbeat, which is coming from the ventricles as a result of the loss of atrial coordination of timing. We slow down the ventricular rates, but don't necessarily address the AFib itself. It's the least complicated option. It's the one that's available to just about anybody. It is something that we might use for very early stage AFib where, that patient's not ready for more advanced options yet, but we don't want their heart, racing at 140, 150 beats per minute when they do have their AFib episodes that are still few and far between. We might use it for medically frail patients where we don't think that the more advanced rhythm control options are a good idea because we don't want to test the bounds of safety with these more complicated rhythm control options. It's also the least effective option, unfortunately, because it doesn't control symptoms of AFib itself. Some people will, yeah, great, the fast heart rates are better. I don't have quite as much in the way of palpitations, but I still don't feel like my normal self because of the AFib itself. Yeah, my heart rate may be 60, 70, 80 beats per minute as opposed to 150, but the irregularity is still affecting my heart efficiency. And it does not slow the progression of AFib itself, that AFib timeline that we talked about. Whereas rhythm control, in contrast, directly addresses AFib. What our goal is with rhythm control is to actually terminate episodes of atrial fibrillation as well as prevent AFib episodes from happening going forward. It does prevent the AFib progression over time. So that AFib timeline, I usually tell folks, we don't necessarily revert. We don't necessarily turn back the clock on the AFib timeline, although to some extent we may be able to. But really what I'm trying to do is avoid that progression in disease burden over time. We do treat the symptoms of AFib itself, because if we prevent AFib from happening in the first place, then we prevent any of the cardiac inefficiency. We, by definition, prevent the fast heart rates as well if we are able to prevent AFib episodes. And it prevents the consequences of AFib over time. So we reduce the risk of heart failure. We reduce the risk of stroke, although it is really important to understand that unless we get truly perfect control of AFib, which we don't necessarily get with rhythm control, we don't consider this enough of a stroke risk reduction to stop blood thinners if they're otherwise warranted. So generally, there's a stroke prevention arm of treatment, and then there's rhythm control. We kind of do those things in parallel. Longer survival there associated with a couple of question marks. There are very specific, very narrowly defined patient populations in whom we can see some indication of improved survival. But for the most part, when we're talking about controlling AFib, preventing AFib from happening, in the vast majority of patients, if you just say patients with AFib, we don't actually see an improvement in survival by controlling AFib itself. We see an improvement in survival by controlling stroke risk. We see an improvement in quality of life by controlling AFib itself. And so how do we do rhythm control? Well, there's some medications. There's a whole slew of antiarrhythmic drugs. There's about 8, 9, 10 different drugs, depending on kind of which ones you would consider candidates for AFib therapy. There's some that we use more commonly than others. And then there's some procedural options, mainly ablation. So how do we choose between rate and rhythm control? Well, first of all, we don't necessarily have to choose between them in a given patient. We can use them as complementary tools. In most folks in whom I institute rhythm control, I'm also in the back, or really in the front of my mind, thinking about, okay, but if you have an AFib episode, what is our rate control strategy to address the impact of that, so that we make AFib less likely, but we also then still have the insurance policy of preventing strokes, preventing excessive heart rates. Rhythm control is helpful for patients who have symptoms of AFib itself. And really, palpitations is the one that a lot of doctors and nurses will focus on as a kind of a primary symptom of AFib. Palpitations, yeah, they're not great to live with, but to me, the more meaningful symptoms of AFib are the symptoms of heart inefficiency, the fatigue, the lightheadedness, the shortness of breath, that loss of the heart acting as efficiently as possible as a pump. Rhythm control is helpful for folks who have relatively early stage AFib, where we can really have meaningful returns on that investment of exposure to these therapies, but not so early that their episodes are, several years apart, but the kind of early where we're starting to see that progression of atrial fibrillation, but we haven't progressed to the truly late stage AFib. Rhythm control can be helpful when rate control simply isn't working. And some folks, their AFib rates are really, really fast, but then when they come out of AFib, their native rates are really, really slow. And we can't bring one down without making the other one even slower than it already is. So sometimes we go straight to rhythm control for those folks. AFib-related heart failure is a really big one. That's just basically an extension of what we're talking about with this loss of efficiency now over a long enough time to where, as a whole, now, we're actually meeting the criteria for what we would diagnose as heart failure. Rate control is more helpful for patients who are unable to tolerate these more aggressive therapies. Patients in permanent atrial fibrillation. So as we talked about in the AFib timeline, those folks in the really, really late stages of AFib, permanent AFib as a diagnosis there's an implication to that. The implication when we diagnose AFib as permanent, it means we have accepted it as a permanent entity. And we do not expect that patient's heart to ever necessarily come out of AFib. Excuse me. Now, I will say occasionally patients with permanent AFib will surprise us by spontaneously converting to a normal rhythm, but that's highly unlikely. I mean, I could count on probably one hand the number of times I've actually seen somebody appropriately diagnosed with permanent atrial fibrillation who happened to convert to a normal rhythm. Although, it's medicine and anything is possible. We keep that in mind. So what are rhythm control options? So medications, as with everything in life, it's a little bit of a balancing act. Our most effective drugs also, unfortunately, have the most side effects. Our least effective drugs are kind of the least associated with side effects. And so we kind of have to pick our priorities here in terms of how much of a risk exposure are we willing to accept in the interest of efficacy. So I'll just highlight a couple. So amiodarone is a very commonly used drug. It is by far the best antiarrhythmic I have because it is the most effective and it does not have what we would call pro-arrhythmic effects. However, it's also by far the worst antiarrhythmic we have because there's some potential for long-term side effects. Long-term meaning chronic exposure to this medication can set up kind of low-level, very slowly progressive end organ damage, as we call it. And I believe, I haven't specified that, but common things that we talk about with amiodarone is that we need to monitor for the possibility of liver, lung, and thyroid disease, because those are the three organs that will potentially prompt us to stop this medication if there's any sign of trouble. The good news with amiodarone is that it's an insidious enough, it's a slow enough onset of these things that as long as we're doing the homework of routine monitoring for drug toxicity, we will catch those issues long before they become a clinical problem. So we will catch the abnormality on the chest X-ray, assuming that we're actually doing those, and you know, that patient is following up as they should. We'll catch that problem before that patient's actually becoming short of breath, before they end up on, you know, oxygen, or before anything like that, in the vast majority of cases. But certainly, because of the fact that this has to do with cumulative lifetime exposure, you know, in our folks who are 90 years old, in our folks who are 80 plus years old, generally we're a little bit more open to the idea of committing them to long-term amiodarone. Whereas if you give me a 40-year-old who has atrial fibrillation, I'm going to say, boy, I really don't think that this is a good choice for you, because you could potentially be on this medication for 40 or 50 years. I don't like that long-term exposure. There are several mid-range options that kind of have minimal long-term side effects like we're talking about. However, they may be pro-arrhythmic, meaning that as we tilt the balance away from the risk of atrial fibrillation, we may, if it's too much of a good thing, we may actually introduce the risk of ventricular fibrillation, which is a life-threatening emergency. So we have to use these drugs. You know, we have to respect them as a potentially very helpful therapy, but one that we need to understand may have some serious side effects. So we have to do quite a bit of homework to make sure that we initiate these safely, and then we long-term monitor the response to these therapies. And then dronedarone is kind of, it's a cousin of amiodarone. That's why they sound similar. The idea was to develop a drug that has all the efficacy of amiodarone with none of the side effects. And what we got was a drug that genuinely is much, much better in terms of side effects, but unfortunately it lost the majority of its efficacy. So in that way, it's the worst antiarrhythmic because it's the weakest, but it's the best because it's the best tolerated. It does not have pro-arrhythmic effects, and does not have that long-term exposure issue associated with it. But we would only want to use that in relatively early stage AFib, because it's not a particularly efficacious drug. Now, in people with early stage AFib, it's a wonderful option, because I don't necessarily need to go after their AFib with a sledgehammer. So they might just need a light touch, and dronedarone provides that. All right, so what happens when medications are either no longer working for control of AFib, or aren't an option because they're contraindicated because of some, you know, some comorbid conditions that patient might have, or we tried it, they didn't tolerate the medication? What next? Well, there's the ablation procedure. What we're talking about here is, so this is a graphic from a study that is now almost 30 years old, and this was truly a landmark study in AFib management. This is a study that came out of France in the late 90s that looked at, okay, we know that AFib is this chaotic rhythm, that it kind of takes over the entire upper half of the heart. We can't really say, well, where does this reside? Because it kind of resides everywhere. But where does it start? At the moment of transition from a normal rhythm into atrial fibrillation, where is it coming from? And although it's not exclusive to what we call the pulmonary veins, because you can see there's some dots here outside of the pulmonary veins as well, the vast majority of the time, AFib is triggered in the pulmonary veins. What are the pulmonary veins? Well, there are two veins coming from each lung, from the right lung and from the left, that carry freshly oxygenated blood to the left side of the heart to get pumped to the rest of the body. And so what you're seeing here is a patient's actual left atrium. We're looking from the back of the body, so from the posterior surface, if you will. And you can see that these four structures that are coming into the heart. Let me see if I could maybe, hopefully, we can see, I'm not sure if you guys can see my cursor here, but there's two pulmonary veins here on the left side, and there's two pulmonary veins here on the right side. And so what we've done in this patient's heart, you see this array of red and pink dots there. Those are individual lesions where I had gone into this patient's heart and killed heart tissue selectively to create a ring of scar around the pulmonary veins on both the left and the right side. And what we're doing there is electrically silencing those structures to where they're no longer able to communicate with the rest of the heart. This is a procedure. Every procedure has upfront risk associated with it. On the day of the procedure, we talk quite a bit about, hey, this is what, well, really, when we decide to do the procedure ahead of the day of the procedure, we talk about, we need to consider the possibility of side effects from the procedure itself. However, what this does do is spare folks potentially the long-term exposure to antiarrhythmic meds that do have their own kind of more lingering and long-term side effect exposure. And this is the most effective option we actually have to control AFib. It's important to recognize that the full benefit of this procedure takes several months to achieve. Usually we use 3 months as a kind of a rough cutoff for healing from the procedure. During that 3-month window, you're kind of in this vulnerable phase where you may actually still have AFib episodes, and it doesn't necessarily mean anything. It doesn't mean anything in terms of the outcome of the procedure. What it's telling us, if someone's having AFib, is their heart's still healing, and we can't really draw conclusions from that yet. So how effective are these options? So, we don't need to necessarily make this a big intro to statistics class, but what this graph is what we call a survival curve graph. And it's not necessarily talking about survival. What we're referring to here is survival free of AFib episodes. And you can see that in this graph, there's across the bottom here, there's the timeline. And for the first 90 days, that's the 3 months, we're kind of blanking outcomes from the procedure. We're not looking at AFib episodes because, again, it takes that 3 months to get the full healing from the procedure before we can really start to look at outcomes. So past that 3 months, what we're looking at is when we're talking about medications like these antiarrhythmic drugs that we had talked about, by the time we get out to 365 days or 1 year, only about 7% of patients are truly free of any AFib episodes, meaning that 93% of folks during that year after having started this medication have had at least one AFib episode. Now, to be fair, they tend to have fewer AFib episodes, but this is nowhere near a cure. The meds only make AFib episodes less likely, but it's less than 1 in 10 patients that actually truly can go a year without any AFib whatsoever on these medications. Whereas when we're talking about the ablation procedure, in this study, we're looking at about a 70% freedom from AFib a year out from the procedure. And these days, actually, those numbers have gotten a little bit better. And we usually quote people about a mid-80s% freedom from AFib in the first year after the procedure. Another way of looking at that is risk reduction. So this is my little animated arrow showing that we're doing better every year. Another way of looking at this, though, is not as black and white, do you have AFib versus not? Because I think that misses a lot of the point in AFib management. Because we'll be, any electrophysiologist who's worth their salt will tell you up front, there's no such thing as a cure for AFib. We wish there were. At this stage, there's just not. So what we're really looking at is burden reduction. So how does burden reduction look with an ablation? On average, in well-selected patients, in appropriate patients, what we see is a 99% average reduction in AFib burden. So if we compare the amount of time spent in AFib prior to this procedure versus the amount of time spent in AFib after the procedure, on average, we see a dramatic decrease in AFib burden, even though some people will still have some episodes of AFib. Now, I will say that statistic actually makes the procedure sound probably more good than it actually is. So one of these statistics makes it sound worse than it is. The other one makes it sound better than it is. Because unfortunately, I truly wish, I say this to patients all the time, I truly wish we didn't cure anybody's AFib and everybody would just get a 99% reduction across the board. But that's not how that works. A lot of folks do seem to get, at least for a few years, what's approaching a cure. I like to use the word remission, where they don't have any AFib, and that's wonderful. And then there's going to be a proportion of folks that have a dramatic decrease in atrial fibrillation, but not necessarily a complete resolution, which is still okay. But then there's still a minority of folks that, unfortunately, even despite these efforts, will still have AFib and still have AFib in potentially a big way, where we might have to talk about additional measures to control AFib beyond that. All right, so I probably should have clicked through these as I was talking, but there you go. Kind of reflecting what I just said. All right, so with that, I'm going to pause. There's so much more to talk about with AFib. You know, I could talk about this for 6 hours if we had the time. I could get into a lot of details here, but realistically, that's kind of the big picture view of what's out there, what's available, and it's important to understand. I guess the biggest takeaway from this is please talk to your doctor. AFib is a very individual disease. When I meet a patient, whether it's for the first time or for the 10th time, I'm constantly reassessing how AFib fits into their life, fits into their health and their health span, if you want to think of it that way. You know, how many years of life do they still have ahead of them? How do I expect their AFib to progress? You know, in a very weird and counterintuitive way, it's a lot better to be a 90-year-old with your first episode of AFib than to be a 40-year-old with your first episode of AFib, because the reality is that we don't have to worry about how's that 90-year-old going to look in 30 years, which is a long time for their AFib to potentially progress. Whereas a 40-year-old, we really have to think about some very important long-term implications of AFib progression over time. So with that in mind, I will pause and
we do have one question in the chat box right now. What is the relation between central sleep apnea and AFib?
Oh, that is a great question. And let me see if I can pull up the chat box so I can look at these things. Yeah. All right. So let's talk about sleep apnea in general. So sleep apnea is a very large contributor to atrial fibrillation. Sleep apnea actually contributes to all cardiovascular conditions, if you want to think of it this way. So any kind of outcomes, whether we're talking about risk of heart attack, risk of stroke, risk of atrial fibrillation, and even actually at a more foundational level, things like hypertension, diabetes, cholesterol control, sleep apnea contributes to those things. Part of the reason why is because your body's stress hormones are activated when you're not getting adequate sleep. So the deepest, most restorative stages of sleep are the ones that tend to be affected by sleep apnea. The brain senses the lack of gas exchange and the hypoxia that happens from sleep apnea, whether that be central sleep apnea where somebody's obstructing in their throat. That's the classic, snoring. Sometimes people say, I snore myself awake. What they really are talking about is this phenomenon where they're waking up to take a big breath because the brain is sensing this. Or if we're talking about central sleep apnea, that's where the brain is simply not sending the message to the body, hey, it's time to take a breath, because we're not voluntarily breathing. That hypoxia in itself can be a burden on the whole system. As you might imagine, not taking a breath for a while, whether you're awake or asleep, that's a problem. But it then also leads to poor sleep quality, which over time simply tends to activate your body's stress response. And then all of these downstream effects start to come into play. So sleep apnea is very important. Not in everybody that I meet that has AFib, but in a lot of my AFib patients, I would say at least half of my new AFib consults end up going to the sleep clinic as well, because sleep apnea is very much underdiagnosed. It's very common. I refer to it as the silent killer of our day. So for those of you who are old enough to have been around in like maybe the 70s, there was a campaign to really recognize hypertension as the problem that it is, because most people don't necessarily recognize that they're having hypertension because they don't necessarily feel it in a day-to-day, but over time there's cumulative damage to the body. That's what sleep apnea is these days. We need better recognition as a society of the fact that, hey, this is around and it's a real problem. And I'm seeing here a question from Bob.
And then also, okay, Brooke had her hand
Yes.
raised, but she put her question in the chat, it looks like.
Okay. Yeah. Well, so Brooke, if you had your hand raised, let's talk about your question. Can you talk about cardioversion? Of course. So what is cardioversion? Cardioversion is an electrical shock to the heart to terminate usually AFib, sometimes other arrhythmias as well. Think of it like pressing the reboot button on your computer. Effectively, what we're doing is it actually, sometimes we say, oh yeah, we're restoring a normal rhythm. We're really not doing that. What we're doing is we're terminating all rhythm in the heart. And then the sinus node, which is the heart's intrinsic pacemaker, then comes in and says, okay, it's my time to shine. So what a cardioversion accomplishes is getting somebody out of these, we talked about the AFib timeline, and when we start out, we're in paroxysmal pattern of AFib. They're individual episodes that kind of start and stop. Now, when somebody is in persistent AFib, where they go into an episode and it's prolonged, it's not going anywhere. It's not going to terminate on its own. That's what cardioversion. That's the purpose that it serves. It gets them out of that extended episode of AFib. What cardioversion is not is a prevention of the next episode of AFib. So a lot of times when we do a cardioversion, sometimes we'll just do that and say, let's see how you do on your own. If it's your first ever recognized episode of AFib, it could be years before your next one. So sometimes we'll just do a cardioversion and just keep an eye on folks. And in some patients, we do a cardioversion, and at the same time, we're also talking about, okay, but what are we going to do to prevent the next episode? Because this does not prevent the next episode. It's, think of it like this. If you have to reboot your computer once in a while because it's running a little bit slow, not a big deal. But what if there's a malicious virus on your computer that's making it run slow? You can reboot it all you want, but it's still going to run slowly, right? So then we have to take care of the virus itself. So that's where the rhythm control therapies come in addition to the cardioversion. And then,
sorry, doctor. Hey, Laura, this is Ron. At an appropriate time, I have a question.
Okay, Ron.
All right, thank you. So let me, Bob had a question here, and then we'll go to Ron, and then looks like Brooke had another one. So Bob was asking, are wearable devices reliable indicators of AFib? Yeah, so yes and no is my best answer. So they are a great screening tool. That's how I would look at this. So screening tools are very helpful. Screening tools are useful to identify problems before, like as early as possible before they might have been recognized otherwise. Wearable devices are wonderful. They, especially for the first ever recognition of AFib, they may actually help spare somebody a stroke because we caught this before they had a chance to, progress to some kind of consequence. However, any piece of data we have to take with a grain of salt. Now, for what it's worth, the newest generation of wearable devices, Apple Watch came out with this first, and then a lot of other devices have kind of caught on. A wearable device that has EKG capability. So there's you guys might have heard of the Cardia device. It's a little thing where you place your fingers on this little, it's like a little Hershey bar size thing. When we have an EKG, that is a much more reliable way to identify AFib. Now, I will still say, if we're relying on the software in your phone to identify AFib, I would, again, still take that with a grain of salt. But if I can look at the EKG that was the source of that suggestion that somebody might be in AFib, then I can tell you for a fact whether that EKG actually showed AFib or not. So for those of you that happen to have like an Apple Watch or Fitbit or whatever, if you get an alert that says AFib, and it's EKG capable, the most important thing you can do, create an EKG at that time. You can send it to us if you're on my chart and you've already established with us as a patient. You can save it for the next conversation with your physician and show them that EKG. And then we can actually say for a fact, objectively, not just the computer thought, but yes, you had AFib at this very moment. So, okay, so I
It was
believe Ron, was
Ron.
it? Did you say you had a question?
Yeah, Ron had a question.
Yeah, good morning, doctor. About 16 months ago, you put a pacemaker in my chest. I'll be 79 years old in about another month. I also wear a CPAP machine at night. I'm looking and hoping for ways that I wouldn't have to wear the CPAP machine. In your presentation, this Watchman, you spent a little bit of time talking about this product called
Yes, sir.
Watchman. So, in fact, now that I have a pacemaker, 79 years old, I've been wearing a CPAP for three, 4, 5, 6, 7 years, something like that. Are there some things that you might suggest that I could have you and your team take a look at to see if I could get rid of the CPAP?
So Ron, I'm going to say, why don't we plan to have that conversation in a one-to-one conversation next time we see each other? Because realistically, I'm sorry, I should have said this ahead of time. This is meant to be a general discussion, and I'm not trying to put anybody's business out, into the world. And it's also really important to remember that, there's a lot of variables that go into decision making here, and I don't want to give you advice without really having a chance to look at all the details with you. So that sounds more like a clinic question. So why don't we talk about that in clinic?
I understand what you're saying. Thank you.
Yeah, thank you. When we're talking about specifics, when we're talking about the strategy for an individual patient, like I said right there at the last slide, the important thing is to individualize these decisions. I wish that there was a broad strokes kind of one size fits all solution. I'll tell you right now, I would love to be out of a job because we fix these issues and we could just automate the decision making. It's just, maybe it'll happen one day, but it's not going to happen anytime soon. These are very, very individual. It's the art of medicine as much as the science of medicine.
Let me
So
ask,
Brooklyn,
let me ask it this way. I've seen ads on this Watchman. I don't believe that the product has been around for a long period of time. Have there been studies to the general effectiveness or success of this Watchman product?
So what we talked about there with this left atrial appendage closure, that was actually the pictures I was showing were of Watchman. There are other products that are very similar, but as a general rule, the studies have shown that the term technically is non-inferior, that's a fancy statistical term, to being on blood thinners, meaning that it's comparable stroke risk reduction to being on blood thinners. However, I would strongly caution against choosing an option just because it exists. So what I mean by that is, if somebody can take anticoagulant therapy and there's not a compelling reason not to be on it, then that is the therapy that has the most robust evidence behind it. We've at this point had millions of patients, and the approval studies for the blood thinners had over 70,000 patients enrolled, demonstrating efficacy. Whereas the Watchman is really, it's meant as an option for people that are between a rock and a hard place. So as I was talking about earlier, for patients who are both at risk of stroke and cannot be on blood thinners because of the risk of bleeding with blood thinner therapy, back in the day, legitimately, the conversation went, not in so many words, but the general gist of it was, boy, good luck, because we can't do anything. Let's just keep our fingers crossed that you don't have a stroke, because we don't have the option to actually prevent it with medications. Well, now we have a way to do this that's non-medical. However, I would not, and I caution against this all the time in my clinic, where people ask about, well, what about that Watchman thing? How will that help my AFib? Well, frankly, if you could take a blood thinner, it won't. It's just an alternative that is an invasive option that, if you can't take a blood thinner, totally different story. It then gives you a lifeline. But if you can take a blood thinner reasonably, this is really helpful. let's go back to Brooke's question, because she was asking, is there anything we can do besides meds to help push back those next episodes, or is it just going to happen when it happens? Yeah, that's a great question. So meds, ablation, right? Those are the things that I can do. Treating risk factors. So I didn't really put a slide in here about risk factors because, boy, it's a busy slide. But there's a lot of different things that go into this. So control of cardiac risk factors. So basically, I mean, it's a lot of the stuff is going to be common sense. You want to maintain your heart health so that your heart's not under strain, so it's not experiencing those wear and tear kind of things. So when we talk about, risk factors for AFib and making AFib less likely, so treating hypertension, hey, we already know that's a good idea, but yeah, it helps AFib. Treating diabetes, we already know that's a good idea, but it helps prevent AFib. Treating like sleep apnea, right? We know that in its own right helps your overall health, and it helps prevent AFib from happening. Weight loss, right? Because if the heart has to pump blood to just physically more tissue, it has to do more work. It's going to be under strain. Treating related conditions. So if the heart is having to compensate because the lungs are unhealthy, well, taking away the heart's extra workload by treating whatever lung condition might be going on helps reduce AFib. Avoiding cardiotoxins. So everybody knows that smoking or chewing tobacco is bad for the heart. Unfortunately, it's also very addictive. I mean, I don't think most people that utilize tobacco, don't know that it's unhealthy, but putting forth those efforts to avoid putting the heart under strain with tobacco products, I think that's a fairly common sense thing. What a lot of people don't know is that alcohol is just as toxic to the heart as it is to the liver, and alcohol can cause AFib episodes, both in the chronic sense and in the acute sense. There's actually a condition known as holiday heart syndrome, where about 48 hours after things like New Year's Eve or, kind of common stay up late and drink kind of holidays, or possibly just a Saturday night, there is a well-described increased risk of atrial fibrillation. So, that's something that is related. Caffeine use, excessive caffeine use, again, both in the chronic sense and in the acute sense, can lead to increased AFib risk. And then sleep, and unfortunately the poor sleep, caffeine, alcohol triangle, it's kind of a vicious cycle for some folks, because when you get poor sleep, you have to caffeinate. When you caffeinate all day, then you have to have something to kind of wind down with, so people kind of self-medicate with alcohol to help them sleep. But then that also leads to poorer sleep quality, and you just start it all over again the next day. And so unfortunately, it could be a really a really difficult cycle to get out of, and we have to kind of enter it somewhere. So and Brooke, thank you so much for your comment as well. So that's very kind. Are there any other questions? Anybody else that kind of is wondering about anything else we've talked about so far? All right. Well, I thank you all so much for joining. Knowledge really is power, to Brooke's comment. The most important thing I can do for my patients is to inform them. And boy, I wish I had an hour to talk to everybody in my clinic. I genuinely do. Unfortunately, as I'm sure you all know, the nature of this work is such that a lot of people need us, and so we kind of have to kind of keep things very focused at these clinic visits. And that's why I love doing these kind of things, because this is the time to be able to really delve into the details. So even those of you that have a lot of experience with AFib, I hope you learned something new from this. Thank you so much. And please be on the lookout for more of these kind of things, because I love doing this kind of education. I'm going to look forward to doing more.
Thank you, doctor. Thank you, Laura.
Yep, thank you for attending. Just a reminder, I will be sending out a follow-up email with a class evaluation. So if you can fill that out, we really appreciate your input, and thanks for joining us today. Have a great day, everyone.
Thanks, everybody.